Welcome to this presentation on the uncertainty in illness theory as developed by Merle Michel. Merle Michel was born in 1939 in Boston, Massachusetts. She graduated with her BA in 1961 from Boston University and received her MS in psychiatric nursing from the University of California in 1966. She received her MA in social psychology from Claremont Graduate School in 1976 and went on to complete a PhD in 1980, also in social psychology from the Claremont Graduate School. While working on her PhD, she received a National Research Service Award to develop and test the Perceived Ambiguity in Illness Scale, later renamed the Michel Uncertainty in Illness Scale. Part of the motivation for developing her theory came from her experience with her father dying from colon cancer. Her father put a lot of energy into trying to understand his conflicting symptoms and helped her to understand the significance of uncertainty for ill people. The original Uncertainty in Illness theory was published in the Journal of Nursing Scholarship in 1988, and it included this diagram. I'm going to spend a few minutes on this, first as overview and then on the parts, and then come back again to the whole. I believe this is the best way to understand the theory. As you can see, the basic idea is that you have a situation, the stimuli framework, and this leads to uncertainty, and your appraisal of it is what shapes your response and eventually adaptation. The stimuli framework is essentially the experience of illness. The components Michel has identified include the symptom pattern, which is related to the predictability of symptoms, the number of symptoms, and their intensity and frequency. In short, how they affect your life and how you're able to manage those effects. Another component is event familiarity, which is developed with experience. A regular hemodialysis patient, for example, will have a very different experience from one who is going to do only a few emergency treatments. A third component is event congruence, which refers to how the events match our expectations. A person who expects a cure, for example, will experience a lack of congruence when they see a return of symptoms. Of course, a number of things feed into the stimuli framework. Cognitive capacity is one thing, and this is significant not just for the person's innate cognitive abilities, but because disease and stress can affect our cognition. Also strengthening the stimuli framework are external structure providers. Education level is shown to make a difference in strengthening the framework. Social support is an important influence in several ways, both for helping to resolve ambiguity related to illness in the form of peer support and for helping with day-to-day support, which can help with handling uncertainty. Credible authority from healthcare providers also helps patients understand what's happening with their symptoms. An important part of the original theory is that the state of uncertainty is neutral until it is appraised. Two basic processes are used for appraisal: inference and illusion. Inference refers to the way a patient brings their basic beliefs, their locus of control, their general experience, and the knowledge into the interpretation of uncertain events. Illusion is defined as beliefs that are constructed out of uncertainty. Now, Michel points out that this has generally been considered. In the original theory, uncertainty is ultimately appraised as danger or opportunity, and coping mechanisms depend on that appraisal. If the uncertainty is appraised as dangerous, the patient will respond with action or with increased monitoring, looking for more information. If the uncertainty is appraised as opportunity, the coping approach is buffering, including trying to prolong uncertainty in the face of possible negative resolution. And here is the big picture again. So you can see the flow of the theory from the stimuli framework through the appraisal of the situation by inference and illusion, and to coping mechanisms and adaptation. In 1990, 2 years after the Uncertainty in Illness theory was published, Michel reconceptualized the theory to address the outcome of chronic uncertainty, which ideally leads to an expanded worldview based on probabilistic and conditional thinking. Michelle draws on chaos theory, which posits a more complex system in which disorder, nonlinearity, and disequilibrium are all parts of the healthy variability of the overall system. She also questions the Western worldview in which there is little room for uncertainty. In this expanded view, uncertainty can allow for individual growth by acknowledging and accepting uncertainty and using it as a new foundation for building a sense of order. This process also can be blocked by a number of factors, especially a lack of support from care providers and from social resources. In terms of Fawcett's nursing meta-paradigm concepts, Michelle's theory in the reconceptualized version suggests that the person is the individual experiencing illness. Environment is the stimuli frame. Health is a state of balance and equilibrium within the state of uncertainty. And the role of nursing is to provide structure, education, and understanding of a probabilistic worldview. A number of studies have been done using Michelle's theory, so we'll talk about just a couple of those that have been significant. The first one we'll talk about is watchful waiting in prostate cancer, and it includes this diagram of the reconceptualized theory, originally published by Michelle in 1990. This study strongly supported the theory, as men who experienced the uncertainty of prostate cancer evaluated their symptoms and in time came to see the uncertainty as positive, and adapted their worldview related to their new state of uncertainty. Another study tested the model with Taiwanese parents of children with cancer, and also tested 3 reduced versions of the model. It found significant correlation of the parents' experience with the model and the reduced versions. This study underlines the importance of studying the adaptation process in a cultural perspective, and found that in Eastern culture, there was more acceptance of uncertainty and that coping strategies were a new variable in adaptation. Finally, a very new application of the uncertainty in illness theory applied to stroke patients in 2014. In this study, they used Michelle's scales to analyze the level of uncertainty in post-stroke patients. They found that patients experienced uncertainty related to the lack of information, long-term recovery, and financial aspects of their new disabilities. Patients reported adaptation by seeking information and refocusing their attention more to the present and less to the future, and also in finding new norms. This is very consistent with Michelle's reconceptualized version of the theory. To understand Michelle's theory, the 2 references you most need are the 2 statements of the theory as presented in the Journal of Nursing Scholarship. The complete details are listed on this slide for your convenience. The article entitled Uncertainty in Illness lays out the original theory. The reconceptualized version is detailed in the article entitled Reconceptualization of the Uncertainty in Illness Theory.